Good morning, everybody. My name is Terry Helton, and I am the chair of the Coalition for Compassionate Care for Ventura County. I want to welcome everybody today. It is exciting to see all of your faces, and I'm hoping someday soon that we can see everybody's faces in person and interact again like we did on April 28th. That was a lot of fun, and it was very meaningful. So I would like to say that we're here today for a very special event that often comes up in questioning, and that's about capacity and competency. And we have the pleasure of having somebody who's going to start us off with the conversation. But our intent of this meeting is it's not just somebody who's going to present, but it is an opportunity to have a discussion and a conversation and understand it better. And that is what we're hoping in the future that most of our events will be, is something where we learn from each other, we discuss it, and we bring our ideas and our thoughts and our doubts to the forefront. So saying that, and knowing that we are all busy people, I would like to tell you a little bit about, hang on a second, I got myself all, to tell you a little bit about the presenter today. Well, I'm going to lie. I've lost my. Okay, so Rebecca Reyes is a physician and a lawyer. She's a graduate of both medical and law schools. Rebecca completed her psychiatry residency training at UCLA in Los Angeles in 2002 and began working immediately as the director of the adult inpatient ICU, a high intensity unit at Vista Del Mar Hospital in Ventura. While at Vista, Rebecca spearheaded the military PTSD inpatient treatment program and served as a director until she retired from inpatient psychiatry in 2016. While directing these programs, Rebecca also served as the medical director of Sober College Addiction Treatment Program, a La Ventana Stepping Stones Addiction Treatment Program, and the Bella Vita Eating Disorders Treatment Program. Additionally, Rebecca ran a thriving private practice focused primarily on the treatment of anxiety and mood disorders. Rebecca recently joined ASCLEPES Research Centers as a sub-investigator and rater. Rebecca also works as a consultant for Alliance for Wellness, a psychiatric group practicing in Los Angeles, Orange, and San Diego counties. Alliance for Wellness plans to provide psychiatric care to patients in Ventura County as soon as summer. So saying all that, part of what I would like to add to this conversation is that she had met with Dr. Jazz Korber Hermani, who happens to be in India right now and probably will not be able to attend this. And she met with Diana Hawkes, both people who is the palliative care director of Community Memorial till recently. And they had a big discussion about this and what goes on in hospitals and whether physicians are needed or psychiatrists are needed. And that will be part of the discussion today after Rebecca gets started. So saying all that, I would like to introduce Rebecca right now.
A circle with a CD in the middle of it. So
oh, please do me a
Hi,
favor.
everybody.
If you would mute yourselves. Go ahead, Rebecca.
Okay. Hi, everybody. I'm so glad that you're all here today. And I'd like to just start off by saying that we really want this to be an informal kind of discussion type of scenario. I have prepared some slides just to give some background information, but we'll be talking about general concepts related to capacity. And we're going to go over a few definitions just briefly, and then look at what components make up a good capacity evaluation, and then think about how this might relate to dementia just generally. We won't take a deep dive into that, but I know that a lot of us here work with the elderly. And so it's an extra consideration when thinking about capacity. And then we'll go over some case studies that I think will really stimulate a little bit of conversation. But all that being said, and that being the general framework, if at any point you want to interrupt me, ask me a question, or make a comment, or relate something that's happened to you personally as a clinician, I'm more than happy to do that, and we should do that. So less lecture, more discussion type of thing for today. We also won't be talking necessarily about advanced directives, medical power of attorney, those sorts of things in this particular discussion. But we will kind of touch on them just briefly as how they relate to capacity just a little bit. I had my first introduction to conducting an assessment for capacity when I was chief resident of the consultation liaison service at UCLA during my residency. And, it was moving and it really affected me. And I never forgot it. And then of course I've done so many assessments after that. But it was a man with cancer who was choosing not to have treatment, and he was a young man. But long story short, I found him to have the capacity to make the decision. And he decided that he did not want the treatment. And so these are very big, heavy decisions usually, but we'll talk about that too, kind of scaling our assessment of capacity to the situation at hand. Major decisions versus minor medical decisions, and kind of how we look at that. Anyhow, so let's go ahead and we'll move to slide 2 if we can. Okay, so we'll just start with this very general definition of capacity. And so capacity, when you're thinking about it, is a patient's, and if we can move forward one more, Terry, a patient's ability to understand the nature and consequences of a decision. And this is a medical decision typically. And it's a proposal of a healthcare treatment, perhaps. And that's the way you want to kind of maybe be thinking about this. So the ability to understand the significant risks, benefits, alternatives to treatment, what it means to refuse all treatment. And it's determined by a clinician. This can be an MD, a DO, a PA, or an NP. The reason why this is determined by a clinician, we'll talk about a little bit down in a few more slides, but just briefly, a capacity assessment is actually also an order that will go in the chart. So you have to be able to write the orders in the chart. And for that reason, typically, a clinician who has order writing kind of power for the chart is the one who makes this assessment. Now, that is not to say that everybody on the team can't contribute to the assessment process, the discussion, and help with making the appropriate decision for the patient. So everybody on the team is necessary to make this decision. This is not the clinician just operating in a vacuum. Okay, and next slide, please. Great. So competency is a legal term. It is different from thinking about capacity. Competency usually has to do with sort of a global assessment of something that we are wondering about this patient. Are they competent to perhaps stand trial, or competent to make kind of a global decision that is not related necessarily to a specific medical decision. So when we think about competency, we want to be thinking about a judge makes this decision, not a clinician. And it's something that will affect this patient globally moving forward in perhaps all areas of their life. The medical assessment of capacity is made by the clinician, and it has to do with a snapshot in time, a moment in time. And it does not apply to anything that came before or after in terms of a decision. It is specifically about the issue that you're deciding at hand in that moment, in that time. So we want to keep that in mind. And we remember that healthcare is any care or treatment, service, or procedure that we use to maintain, diagnose, or otherwise affect a person's physical or mental condition. And we're talking in capacity here in this particular discussion about healthcare decisions, right? And so a healthcare decision is made by a patient or an agent for the patient or a conservator, surrogate regarding the patient's healthcare. Today, we're going to talk primarily about capacity decisions that are made by the patient themselves, and how do by the clinician in regards to the patient, and not having maybe a surrogate or conservator making these decisions. But what do we do when we have a patient in our office or in the hospital or somewhere else that needs to make a medical decision? How do we determine if they have capacity? Okay, we can move on to the next slide. Okay, and interestingly, this idea of informed consent is something that we really have to think about as kind of underlying everything that has to do with the capacity assessment. Informed consent is something that we need to obtain from our patients in order to provide medical treatment in almost every case. Medical emergencies are kind of the exception to this. We won't be talking about that today. So when we think about informed consent, we have to think about, well, what are the components of that? Well, we provide a description of the disease. We talk about treatment options. What are the risk benefits of treatment? What happens if we have no treatment? And what are alternatives to treatment? And an essential element to the informed consent process is that the patient consenting, giving his or her or their informed consent, must have capacity to do so. Okay, next slide, please. So that brings us back to capacity. Here's that definition again. And so the capacity is the patient's ability to understand, really understand the nature and consequences of a decision, in this particular case, a healthcare decision, proposed healthcare. They have something physically that needs to be helped. What is their capacity to understand this? And so what are the benefits, risks, alternatives to this treatment that is being offered by the clinician for this medical condition? Okay, and next, please. So there are several risk factors that we think about when we're talking about assessing capacity and looking at impaired medical decision-making. And so, you know, there's just some things that jump out right away that we need to kind of be on alert. If we have this particular scenario, a patient with one of these conditions, or perhaps we have a patient less than 18 years old, we have issues with informed consent and involving parents, etc. Age older than 85 years old just should sort of put a flag up for you to be extra careful in looking at capacity, but by no means does it indicate that if you're 85 years old or older that you lack capacity. It's just to keep that little extra level of looking at it closely. Chronic neurologic or psychiatric conditions. If there's a significant cultural or language barrier, we need to be especially sensitive to this and to make sure that we are understanding the role that these might be playing in a patient's decision. And then sometimes a lower education level is a flag. If a person doesn't have much experience with the medicine in general, talking to doctors, they don't maybe have a lot of prior exposure to kind of medical concepts and things like that. And so we'll move to the next slide. Okay. And so, generally speaking, a patient's ability to understand the nature and consequences of their healthcare decision and to communicate that decision is kind of just the take home of what capacity is, that one sentence right there. Can they understand what it is? Can they communicate that to you as a clinician? And can they also talk about risk benefits, side effects, treatment alternatives to what you are proposing for their healthcare? This requires a direct interview with the subject using open-ended questions. This cannot be done in any other way. In the age of the pandemic, yes, it can be done via Zoom, but you cannot make a decision about someone's capacity without directly talking to the person. So that's a really big component of that. Okay, we can move on to the next slide, please. So I mentioned this just briefly in the beginning, but I really want to drive this point home that capacity assessments can be performed by any licensed physician, DO, PA, NP, anyone who has the ability to write an order in the chart. Historically, psychiatrists and psychologists are regarded as quote unquote experts in this area, but that is not really at all, how it is, I think, in this day and age. And it's very important that all clinicians develop a comfort level with assessing capacity, especially when it is a scenario where maybe it's I don't want to say a lower stakes, but the medical decision that's being decided upon is maybe more minor and that sort of thing. I think a psychiatrist should really only be called in if the clinician feels uncomfortable about making the decision, or if it's a very complicated decision, then you might want to call in a psychiatrist to consult or a psychologist, but it is by no means required that a psychiatrist or psychologist is involved to make this decision. And that being said, one of the reasons that we want to make sure that people who are making these decisions are allowed to write the orders in the chart, et cetera, drop notes into the chart about the medical decision specifically is because no matter what amount of talking we do with the patient, no matter how great our assessment is, no matter how much we've made quote unquote the right decision and really determine this, without the order and without the proper documentation, as usual, if it's not in the chart, we can't prove that we've done it, that we've really done what's in the patient's best interest by doing a thorough assessment of capacity. So we really need to make sure that this assessment is documented, and that would include the date that you talk to the patient or several dates over which you talk to the patient to make this determination, and names of the relatives that you talk to, and relationship to the patient, the concerns that were raised by the patient and by family members, and solutions that you offered as the clinician or the team offered, and medications, dosages, side effects, etc. Everything needs to be documented in your chart and in your notes. Okay, next slide. Okay. Great. So the duration of a decision in terms of an assessment for capacity, like we mentioned earlier, opposite of competency, a capacity decision is not global in scope. Okay. So for a particular decision, the person will either lack capacity or the person won't lack capacity. And it's for that decision specifically. If another decision comes up the next day, then a capacity assessment would have to be done and apply to a different type of medical decision that comes up the next day. And so we really want to be thinking about this as within the time and situation that this evaluation took place regarding this particular medical decision, and it cannot be applied to any other kind of aspect of treatment. It can only be applied to that particular decision. So for example, if a patient says, I don't want chemo for my cancer, we can't then assume that they don't want radiation. And for example, if we found that they had capacity to refuse the chemotherapy, we cannot just apply that to, do they have capacity to refuse radiation, or maybe oral therapy for their cancer, or maybe, X, Y, and Z surgery, etc. So we have to look at that kind of each decision. Most of the time, the determination of capacity is implicit. So the vast majority of people that you're treating and that you're seeing in your clinics and in the hospital and everywhere else, they're not going to lack capacity to make decisions about their healthcare. And as medical professionals and members of the treatment team, we have to respect their decisions in that regard. Okay, we can move on to the next slide. So As you'll recall, that we mentioned a little bit earlier, the doctrine of informed consent includes description of the disease, treatment options, risks and benefits, side effects for treating that disease, potential for complications, alternatives to suggested treatment. And so this also includes the idea of having no treatment. A person must have capacity in order to make a decision and give informed consent. And so you cannot obtain a valid informed consent without assessing capacity. And so remember that capacity assessments should be scaled to the degree of illness and mental impairment that you are looking at with a particular patient and the medical decision that you're talking about. Okay, and we can go on to the next. Okay, so initial capacity assessment consists of an examination of what? It consists of the following stuff, and it's kind of what you would expect. You know, initially you're face to face with the patient and you're looking at the patient's general appearance, level of consciousness, orientation to self, time, situation. You observe behavior and affect, and you do all this initially to kind of look at where this person is as you come into this before you even start to talk about the medical decision. And then we're going to ascertain that person's ability to understand and comprehend medical information. And so oftentimes, you know, this is really brief, and we walk in and we look at a patient, we talk to a patient and we say, wow, this person really understands what's going on there. And we don't have any concern about needing to do a formal capacity assessment. But sometimes on exam initially, or initial conversation, we might say to ourselves, oh, this is maybe going to require a little bit more in-depth evaluation, a little bit more in-depth assessment. And so we need to take this a little bit further and have this evaluation of capacity. Now, we have certain tools that we can use to help us with capacity decisions. And one of those is a tool called the Aid to Capacity Evaluation, ACE, or assessment. And we'll talk about this just a couple on the next slide. So let's go ahead and move forward. Okay, so we have these 4 elements of capacity. You've probably all seen them or read about them or thought about them in your clinical practices. But basically, capacity assessments are based on a determination of these 4 things. So it's an understanding and retention of information, appreciation of what this condition is that you're talking to your patient about, and what level of insight do they have about it. And then not just that, but are they able to communicate their choice regarding what they want in terms of either accepting treatment, not accepting treatment, maybe accepting parts of the treatment and refusing other parts. And then what are the reasons for those choices? And so all 4 of these capabilities have to be present for a decision-making capacity to exist. Now, there's something like we just mentioned called the ACE, and the ACE is something that can be found online. If we were meeting in person, I would have handed you all a copy of it. But if you want to jot down this this note, it is called the Aid to Capacity Evaluation. And if you Google this, it is right there for you to look at. This is a free assessment. There's no copyright restriction to this assessment. You can pull it offline, you can copy it, you can use it to make your decisions. It was developed by the University of Toronto, and it is really, really helpful, not only to help you and the team make this decision about whether a patient has capacity, but it is also really, speaking from the legal aspect, really nice to show that you did use this particular aid in making your decision. You don't have to, there is no requirement for this. The only requirements for a capacity decision are that it's a clinician making the ultimate order, and that there are these four pieces of the assessment that are present: the understanding, appreciation, communication, and reasons. But if you're like me, a really nice assessment tool, I think of that as very helpful, and I really think that's a great idea. So it gives you, for example, some sample ways to ask questions about these different elements. So, for example, about the medical condition, the understanding of what's going on, you could ask them, what problems are you having right now? You know, what's bothering you the most, and why are you in the hospital? Rather than kind of jumping in and saying, well, I've diagnosed you with cancer. Do you know what cancer is? You can sort of approach it more open-ended, and this gives you kind of a really good guide of some of those potential questions. Sometimes in these assessments, it's easy to get a little bit tongue-tied and feel kind of lost at times when talking to the patient, because these are really things that we're talking about.
Rebecca,
and it's nice to be able to kind of,
Can I ask you to type that into the chat for everybody to see that address, that name, and so
absolutely.
That would help everybody.
Yeah, so let me go ahead.
Because
of
it
course,
sounds
hold on
like
one
even
sec,
though it might help people in the community who are working with people, individuals, to kind of have that knowledge, and then they would know whether to refer, you know, how to refer to a physician or somebody who needs to make that, help make that decision. So having this guide sounds like a real positive
exactly.
thing.
Absolutely. So if you start to like go through this guide with your patient, and you are kind of determining, wow, you know, maybe the level of understanding isn't there, or I think they understand, but they're not able to communicate to me what it really means, so I'm not actually sure. This is a really, really nice handy tool. And I think I might have just sent that not to everyone, but to Vanessa. Sorry, Vanessa. Hold on. Everyone, there we go. So I think that you know, just bearing in mind that this is a good thing, here we go, to look up, to have a copy of at the workplace, just to kind of guide everybody. And then it has like this particular, when you look this up, you'll probably find too, there's also kind of like a workshop piece to using it that you can do with people at the workplace where you are, and kind of role play some of these capacity assessments or the idea of that. So I think that's kind of nice too, and that can be really helpful. All right, so we're going to move on to the next slide. And just briefly, as always, we must take cultural considerations into play, and understand that we might not be aware of cultural, religious, different kind of components that are important to the patient and make up who they are. We might not be aware of those, and they might be influencing this person's decision. And so we want to be highly, highly aware of that. And if we aren't understanding what that is, we need to call somebody who can help us to understand, because it may be absolutely 100% the most important thing to this patient that X, Y, and Z doesn't happen because it's based on something that they believe culturally or one of their religious beliefs. And just because we don't understand that, we can't say, oh, they lack the capacity to make this decision. This doesn't make any sense to me, or something like that. So just be aware of bias and cultural equivalence when you're making these assessments. You know, what is the person's perception of going to the hospital even, or what does disability mean to this person, even within their family, and then within their greater community. All of these things can come into play with a capacity decision. Okay, moving on. So just talking briefly about capacity and dementia. It's very, very important to realize that when we have a patient with dementia of varying degrees, we do need to be thinking about capacity, especially because, you know, we need to talk about informed consent for treatment, participating in research. I work at a research center and we work with elderly patients. And so the idea is, how do we protect these patients when there may be a lack of ability, to actually give informed consent because there is no capacity to do so. Okay, next slide. And so just remember, off the bat, the law assumes that all adults have the decision-making capacity to make decisions about their healthcare. That's where we start from. And we have to have evidence to the contrary that would then sort of trigger that assessment of capacity, or that belief that someone doesn't have capacity to make a healthcare decision. So patients with dementia can't be assumed to have impaired capacity. However, if a person does have a significant cognitive disorder, then and we know that, then we do need to look at capacity kind of in every situation. So, and this can be really, really nuanced. So it might be that someone with dementia has the capacity to appoint a healthcare proxy, but maybe not to execute a living will. Or a person with dementia might have decision-making capacity for day-to-day things about their daily routine, but not complex medical decisions. So just generally speaking, that's something that we want to keep in mind and think about when we're talking about cases of cognitive, cognitive disorders and dementia. Next slide, please. So there's no exact correlation between any measure of cognitive impairment and the presence of decision-making capacity. Two people with the same score on a particular cognitive test might have different decision-making capacity. But oftentimes, in addition to talking to your patient, their family, people involved in their life, we will maybe do a couple diagnostic tests, perhaps. And so we might want to look at the MMSE or other assessment tools just to kind of see where our particular patient is at in terms of that. The MMSE, as you guys probably already know, I like it because it's really widely used. It's really easy to use and administer. It requires no formal training to rate with. And studies have shown that there is potentially a correlation with the MMSE score and then a likelihood that a person will either have impaired capacity or will not. So remember, in capacity, there's no kind of hard, yes, if they score this, we can say they don't have capacity. It's this kind of big assessment that requires all the moving parts, but this is one piece that can be helpful. So for example, if you have a score below 16 on the MMSE, it's been shown to be highly correlated with impaired capacity. And so you can kind of use that as one element. And MMSEs are probably things that a lot of you are using in your offices or when you're with patients, just to kind of see where they are cognitively, especially in the initial assessments of cognitive functioning. And so just bear that in mind, that that's an easy tool that we can, along with the interview, just to put all these pieces together. And then along with consultation, either somebody with, if it's complicated, a psychiatrist or a psychologist, or, if there's cultural issues, talking to somebody with expertise in that area before you make your determination. Okay, and so that's kind of the basic, and that took a little bit longer than I wanted to, I'm so sorry, but that's the basic kind of underpinning of capacity and what we have to think about initially when we're assessing someone who we think, oh gosh, they might need to have this formal assessment. They might not really be able to give us informed consent for the treatment. And so I just put up this vignette here for Mr. X, and we can look at it and then we can have a little discussion if you guys like, and if you have any questions. So we can start to delve into that. Mr. X is a 75-year-old male. He has diabetes, hypertension, and end-stage kidney failure. He's currently receiving hemodialysis Okay, so he's accepting that treatment and receiving hemodialysis. And he also has a below the knee amputation. So he fell, he was brought to the hospital. It was his third fall in 2 months. On physical exam, shows malnutrition, dehydration, and early stage bed sores. So the social worker recommends a skilled nursing facility. PT also recommends placement in a skilled nursing facility, and he's refusing. So they call in psychiatry to evaluate his capacity to refuse this placement to the skilled nursing facility. So just on the face of it, does anybody have any kind of thoughts about, given what we've talked about, just kind of looking at this, what does this kind of trigger within you guys as far as capacity and thinking about that with Mr. X? Does anybody want to give a thought? Okay, well, you know what?
Oh.
If you're kind of thinking, gosh, oh, we have someone who wants to say something. Okay.
Hi, this is Irene. Good morning.
Hi,
I'm just
good
wondering
morning.
how his physical ailments are impacting his mental health at that point in time. So like the hypertension and the kidney failure, like how is that? I guess I'd want to talk to the physician first and find out how that might be impacting him before I move forward.
That is excellent, Irene. Yes, and this is such an important point, because one of the things when we're assessing capacity to make a medical decision or a healthcare decision is this idea that whenever possible, can we be looking at this scenario and have this particular person in front of us at their baseline functioning? So we know that many of these medical conditions and psychiatric conditions can cause an alteration in mental functioning, cognitive functioning from the baseline. So yeah, let's talk to, if I was a psychiatrist coming in, let's talk to the primary care physician. Let's talk to the clinical team. Let's look at the labs. Let's look at everything and see, is there something we can correct? Is there hyponatremia? Is there hyperkalemia? Is there an infection? What can we correct first before we make this decision? Because we cannot assess someone's capacity in the context of a medical problem that is not kind of at its baseline, you know? So an emergent medical problem or an emerging medical problem, we need to look at that and try to fix that wherever we can before we continue on with an assessment. So really good question, Irene. Okay, so next slide.
I'd love to say something as well.
Sure. Yeah, I can hear you, Martha. Hi.
I guess I would want to expand the discussion as well, because it's not uncommon to not want to go to a SNF, and that doesn't necessarily mean someone's making poor choices, but to discuss what type of home care he would be willing to accept as well.
100% yes. This would come into that assessment, because when presenting Mr. X with the decision, will you take our recommendation and enter a SNF for a while at our skilled nursing facility, or won't you? And what are you kind of willing to accept? These are the things that we need to give as options to the patient. So you're right. Well, is there something besides a skilled nursing facility that you would be able to accept? And so we'll talk about that as we get to the next slide. And Terry, if we can go to the next slide.
Well, actually,
we can
I was
see
going to
that,
say, I'm not sure we're through with the discussion here, Rebecca. So Lynette, did you have something you wanted to ask? No, I don't see that. Well, I have a question, because there's something totally missing from this picture that's really important. I'm not seeing social support. And that's something that needs to be asked. Is there family? Yes. Is he living on his own? Or is he living with somebody? What's the whole context of that?
Exactly. That is something that we need to determine, and remembering that talking to family members is one of those critical pieces when we are making a decision about capacity. And so in a particular case where we're wondering, well, if someone doesn't want to go to this recommended treatment facility, but they want to go home, what are their social supports? They're exactly right. Who can help them? So Mr. X had nobody really that could take up that slack, could come to his house, could support and help him. But if we move to the next slide, Terry, I'll show you kind of what he was, what was found. So he was found to be alert, engaged, had a bright affect. His thoughts were linear and goal directed. There was no evidence of cognitive impairment in any way. He had explained that he had been independent his whole life, valued his independence like we all do. He said, I would rather die than live anywhere else than my own home. He understood he was in poor health, but he agreed to engage in additional services at home, right? That could help address some of these health concerns. But he stated that if that wasn't enough, if the doctors didn't agree to that and the team, he would prefer to go home and accept the consequences, without support, rather than being placed in a facility. And so moving on to the decision of the psychiatrist did find that Mr. X, and that's the next slide, had capacity to make decisions regarding his discharge. So the medical team was advised by the psychiatrist to maximize Mr. X's supports at home, even if the team thought this wasn't the right decision, even if the team thought that, he could have better care in a facility and more attention. The assessment was made that Mr. X had capacity and he was able to discharge home. So this brings us to kind of these ethical formulations. If we move to the next slide, Terry, we can see that there's often a conflict, right, between respecting patient autonomy and then the duty to provide beneficence to the patient. Like, do no harm. We want to help everyone we can, and we want to respect autonomy. And we might feel really overprotective of our patients in this particular scenario, especially if we feel that they're making unsafe decisions. And we might begin to really question this. And, that's something that we need to be very, very aware of. That's coming into play as like our feelings as the clinician, right? We don't operate in a vacuum. We often have relationships with these patients, and we have to sort of try to put our feelings aside and respect our patients' values and what they want to do in the context of the decision-making process if they are found to have capacity. So just to be very aware of that, when we're going through this. And next slide, a little bit more about the ethical formulation. If there's a case where there's impairment of executive function and a thought process impairment, a decision making process, these impairments, because of executive functioning, then that can be an issue, and we need to bear that in mind. Now with Mr. X, he was found to have no cognitive impairment, and his thought process was linear and goal directed, and there was no disorder of thought content. But for example, if you have an elderly patient, there's medical issues and some executive function, maybe this patient can tell her clinician what she's supposed to do to stay safe and healthy, but when she's at home by herself, she constantly forgets to take her medications and has a problem taking care of herself. So maybe she can indicate her preferences and generally has an understanding of what the medical plan is, might even be able to say, when I'm home, I need to take my medication. But then when she gets home, because of problems with executive functioning impairment in this, she might not be able to carry out what the medical plan is. And in this case, this person would lack capacity because they need to be able to understand what's happening, articulate what's happening, accept the medical care, and actually follow through with the medical care and take the medical care. So that's an interesting kind of nuance to that. So, you know, Mr. X did not lack capacity and he had no problem with executive functioning, but this particular patient that we just conceived of, she does.
So with
And
this,
so that makes that. Mhm.
would capacity and competency cross over each other here? Because she's not competent to follow through?
Yes and no. I think that there is that probably with this patient, the issue that she would need a lot. So, you know, making this assessment that she doesn't have capacity based on this and this lack of follow through that she's just not able to follow through. But then what does that mean, right? Moving forward from there. It's fine that we say she doesn't have the capacity, but now what do we do? And yes, Terry, this might be the scenario then where there is a deep dive into competency in general for you know, medical treatment specifically. Is she going to be required to take medications? Is she competent to even, you know, live in her house alone if she's unable to care for herself there? And that would then fall into the domain of a legal process. Yeah, so that's a little bit more complicated. Mrs. Z, 71-year-old female with heart disease, hypertension, moderate dementia, chronic renal insufficiency. She's admitted after a fall as well. And she lives in an assisted living facility. Her husband died a year ago. Her niece is at her bedside. Amazing, because we have a family member who's there, a family member who's involved, and she can give information. Evaluation with Mrs. Z reveals that she's alert, oriented to person. She states it's 1988, but that's really the only deficit seen, as well as thinking that she's in a clinic instead of a hospital ER. So a little kind of questionable as to her cognitive functioning, but not too bad. Remainder of her exam is unremarkable. Her niece is able to say she does not like medical care. And her most recent labs are from 3 years ago. So we can move to the next slide, but what does everybody think on the face of it with Mrs. Z? It's a little bit different than Mr. X because we see that she hasn't received medical care and had labs, that is, for 3 years. And we know right away that she doesn't like medical care. And we have a couple of kind of red flags on the cognitive assessment, initial cognitive assessment as far as orientation. So let's move ahead to the next slide. And it shows us that her labs revealed that her kidney function was really impaired and that she would likely require long-term hemodialysis. And when she was told about this, so this specific decision, you're going to need hemodialysis, that's what we recommend, she stated no. And her niece reported she wasn't surprised. This was not something that surprises her because she had previously refused a cardiac cath in the 90s and that she's a minimalist when it comes to medical interventions. And she just didn't want to have this treatment. And the clinician explains to the patient and her niece that dialysis would be a procedure that would, you know, replace her failing kidneys, not replace them, but help them to do what they would have done and to, you know, help her to live longer. And that failure to pursue this would most likely result in her dying. And so this is a big, big decision. It is life and death. Let's move on to the next slide and see kind of what we think about here. So having clearly communicated her choice, the clinician asked the patient if she understood the situation. She said, yeah, my kidneys are failing. That's causing my potassium to rise. And he asked her what that meant. She was able to say they aren't going to function on their own. And I might die from this, right? And so just hearing that, do you guys think that she has capacity or she doesn't have capacity? Just knowing what you know, these basic kind of facts here. What would your gut tell you?
I think she has capacity.
I think you're right.
would also,
Yep.
I would concur. I
She
would
does.
say that she does, yeah.
Yeah, she does. She does. And one of the helpful things that we have here is also having her niece to give context for this decision that she's making. And this is not out of character. This is not against the grain. For Mrs. Z, this is very much in lockstep with how she feels about medical treatment and what she wants done to her body. Refusing a cardiac cath many, many years ago, that's a major medical procedure that she refused. And then, from her perspective, still lived afterwards. So, this is something to keep in mind, but it's nice that we have the niece. You guys are exactly right. If we go on to the next slide.
Dr. Reyes, I have a question before we move on.
Sure.
So
Sure.
just having worked in dialysis for a couple of years, I wonder, like, knowing that there's the toxicity that builds up and that sort of thing, like if she were in the hospital, would they, at that point in time, would she really get, or would they kind of clear her up with acute dialysis and inpatient and then talk to her about long-term treatment, or is this just kind of for the sake of the scenario? I'm just curious about that.
Yeah, so for the sake of this scenario and just kind of generally speaking about capacity, I think we would assume that she wouldn't get any further like dialysis treatment in the hospital, that she's refusing all of that, and she would be discharged home and she would be allowed to do that. However, there are layers and layers and layers, as you say, and you know much more about this than me, and having worked in a hemodialysis clinic, but there are layers to the treatment process. And in reality, if we were introducing the idea of you need hemodialysis for your kidney failure to a person who'd never had hemodialysis before, then we'd want to kind of outline the layers. You can do this here, you can have a treatment here, we can kind of prop you up a little bit, you can accept that here while you're here, and then you can go home and refuse all other hemodialysis treatments, but this will help you in the short term, right? Or you can you only want to come in once a week, okay, maybe that's okay, rather than 3 times a week, if that's what you're willing to accept. So kind of this idea that we're going to scale this discussion and these decisions to
Gotcha.
the degree that we need to. Yeah. So it doesn't have to be a solid black and white in terms of you either want dialysis or you don't, but it could be, well, here's what I'm willing to accept. Or I'm only willing to accept dialysis when my niece can come with me, for example. I mean, we really have to look at what is it that's kind of the hang up and what is it that's the motivation, and then work with that if we can. And but really good question. Yeah.
In the second, oh, go ahead, Terry.
I was
I was just going to say, only quick follow-up question then, in regards to, do you also utilize kind of a biopsychosocial spiritual approach to the assessment, like in the initial pieces when you're trying to determine capacity?
Well, I was going to go to the what matters to the person.
Right, what matters? Well, exactly. And this is, I think, so much harder to do when you this is your first contact with a particular person. But let's say that this is someone that you've been treating, or and something has arisen, and now you have to talk about this capacity decision with them. Everything that has led you to this point with this particular person should be included in your assessment. And just because we need these 4 components that we talk about, and maybe you're looking at the ACE and you're like, well, here's the questions I'm supposed to ask. In terms of your decision-making process, what the team's discussing with the family and with the patient, and then privately the team, talking about this dilemma, and then also what you're documenting. So you can document many pages in the chart of what is informing your decision, if you can, because the more that we have kind of illustrated that we've looked at everything, that we have this really good grasp of what is driving this decision, what is it? Then that's really, really important. So the biopsychosocial formulation, interviews with the family, what we know about this patient, how he's been functioning over the past 5 years that he's been in treatment for X, Y, and Z with us. And now this cropped up and now he's refusing this, that sort of thing. All that should be looked at. Absolutely. Not forgetting to include those 4 elements, but you can certainly, and it's amazing too, think about all these other things and put that down too, in your chart, in your notes, in everything that that you've thought about. Yeah, so yep, Mrs. Z has capacity, and she has a family member who confirms that she's not surprised that this decision is being made, and she just wants to let things run their natural course. And in her case, even though she thought it was 1988, and even though she thought she was in a clinic, not at the ER, but she knew she was in a medical facility, because she could understand everything that was being recommended and what it meant to not accept the treatment and be able to communicate that back, she has capacity. Yeah. Okay. And I know that we're getting like a little bit short on time. So I could we can do another one, but we could open it up for discussion a little bit more. Do people have anything they want to let us know about or talk about in terms of your own capacity experiences with your patients and people you've cared for? Just open that up for some discussion.
I have a question. Do you think that...
Sure. Hi, Kenneth.
Hey there. Do you think that clinicians in making capacity determinations are influenced by whether the patient has an agent under a healthcare directive, and or whether the clinician believes that agent is him or herself is rational?
Yeah, I mean, I'm just going to say yes to that. I think so. And so, I don't have any clinical I don't have any study I can turn to talk about that and say, well, yeah, we know that this is happening in terms of how clinicians are feeling in these scenarios. But yeah, I definitely, even in my own family, I was having a conversation with my sister recently where I said, we got to talk about dad and decisions moving forward if something happens, because my dad's getting pretty old. And we were like, well, it definitely can't be his wife doing this, because she's not rational about most things, And so if you are doing a capacity assessment and your family members that don't seem reliable or don't seem rational, and they're giving you information, we have to take this into account. But we also have to remember that we need to kind of work with ultimately what is the best for the patient, and what are we seeing with the patient, not to sort of discount what family members are saying, and they should certainly be included in the conversation, but maybe the family members would not have capacity to make this decision because they're all over the place, or they have feelings that they can't manage about it, and they can't, really look at it objectively. So in the case that we just talked about, that niece was really clear, like, oh yeah, I know, this is how he's been, and this is why this is the decision that this person is making. But yeah, there can be people who have authority to make decisions for patients that have lost kind of that ability to make that authority, maybe cognitively or otherwise, emotionally. So that's a really hard scenario. And I think I would definitely call in like a psychiatrist or psychologist at that point, maybe just to consult in that case, and maybe your legal team as well, wherever you are. Because that's not as straightforward.
This is why the conversations that we should be having with our loved ones, our friends, are not a once and done. They need to be started when we're younger, and they need to be repeated and continued, so that even as our children are, in older elementary and junior high and high school, it becomes quote unquote a normal part of our life to have conversations about what we want and we don't want. Almost as normal as going, well, I don't want to attend football games because I find them boring. And I know that sounds mundane, but if we can allow our lives to be part of that conversation in the right settings, it's a positive thing. And then those who are involved in the decision-making becomes normal. When we have the conversation with our primary care physicians and those who are involved in our life, makes a difference in the long term. And though we have hospitalists, that information can get transferred and it can be understood. So those are important things to know. I know I made that sound really weird, but it is part of our life. And in the early 1900s, people talked about death and wrote about it, but they never talked about sex. Now think that we have the reverse, and we see talking about sex all the time in different places and how quote unquote normal it is, but people are afraid to talk about death unless it's in these weird movies or whatever. So I just offer that up as an idea.
Yeah. Yeah. And you're right, it's not one and done at all. And it's, in terms of a capacity assessment, like we've been talking about for specific medical decision, that kind of is a one and done in regards to that, right? We know that, like, okay, does this person have the capacity in this moment to refuse or accept this medical treatment? And that is the issue. But what you're talking about, just kind of in terms of who's going to be making these decisions for us down the road, and advanced directives and all these other things. Yes, this is not just a one and done. These things change, situations change, and medical situations, families, and we need to adjust.
Right. So the people who the agent you chose to make that decision for you may have lost capacity before you have. And so you want to make sure you have updated that document for the person who is able to make those decisions, or to have an alternate agent. That's what I was trying to say.
Exactly.
So-
And if the patient hasn't done that, hasn't realized that maybe this person has lost the ability to make the decisions, has lost capacity themselves, for example, then that's our role as the clinician to really kind of work through that with our team. And like I said, wherever you are, there's probably a legal advisor to your hospital or your clinic or even your practice. Make sure that you're bringing in those people to help make these decisions, because that's really tough when it comes to that. Yeah.
Well, in a hospital, they have an ethics team so that they can work on that. But let's say I see Camarillo Healthcare District, or works with individuals, and they might recognize this. Or somebody who's helping place somebody in a residential care might recognize this and need to follow through. What would their steps be? Because they're not a medical person, but they see something that needs to be a person who needs to be cared for, and there's difficulties here. Kalila,
Right.
have you ever seen
Terry,
anything
are you
like
referring-
this?
Well, I'm always having that with, trying to figure out capacity with clients and with family members being involved in their ability to make those decisions as well.
Have you encountered when a family member who's involved, maybe like Kenneth was talking about, just kind of isn't able to give meaningful is maybe the wrong word, but maybe lacks the capacity themselves to help make the decision?
Often. And so sometimes then we're going to call in, adult protective services, because
Okay.
I had that recently with a woman who was living in her home and her husband was unskilled and he couldn't make any decisions, and she had never even paid a bill in her whole life, but there were other issues with her, so we brought APS in.
Okay. Okay. Yeah. That makes sense. That sounds like something that would be one way to go. Absolutely. Maybe also there's a patient's rights advocate, Tina Coates in Ventura County. Maybe contacting her office in these and kind of asking for guidance. She's a lawyer. She's been working in patients' rights and visits the hospitals.
She part of Ventura County Behavioral Health
in regards to this. She works very, very closely with them. Falls under their kind of auspices, but Tina Coates is her name, and she's kind of the one, and she was the one that we turned to when I was working in the hospital if we had legal questions, and she certainly came and looked at everything we were doing as far as capacity assessments, Reyes petitions for medicating a person against their will, those sorts of things. So Tina Coates is a nice kind of person to kind of have in your Rolodex in case you need to call somebody in this regard. You could start there with her office. Yeah.
Thank you.
So would that be true?
I would just add that sometimes what we've seen is maybe the the care facility will contact a son or a daughter and then talk about perhaps a need for a conservatorship. And then that's how we get the case on our side. If both mom and dad are not capable to make decisions, then the other family members can get involved.
Yeah, if you
Yeah,
have those
absolutely.
other family members.
Yes, yes, absolutely.
Can you put Tina Coates' information in? Does anybody have that in the chat box?
Let me see if
If
I
you just
can put it
Google
in
her,
the
she
chat
comes up.
box.
COATES?
Up?
Yeah.
Yes, Tina Coates. Yeah. She also does all the LPS training for Ventura County. It all goes through her. So she's very intimately aware of the county and has been practicing in Ventura a very long time.
So going back to the other idea, let's say we have somebody from Senior Concerns that is recognized of having some capacity issues in this decision making and maybe some family problems with that. Would they refer possibly to the primary care physician to begin this assessment? Looking at other ways that this could be looked
Absolutely.
at.
Absolutely, because we'd want the primary care physician to weigh in, first of all, on any medical, physical issues that might be causing a decline in the cognitive functioning. I mean, maybe it's as simple as this person is on an SSRI and they have hyponatremia and nobody knew about it, you know, and it's affecting their ability to think clearly. So yes, also the primary care physician knows this person. So we talked about how it's so important if you have a relationship with a person, it helps you to make this decision because you know them a little bit more, you know how they operate and how they have made decisions in the past, but also then to make contact with, if needed, a psychiatrist or a psychologist. But again, remember, that's not necessary. The primary care doctor can make the assessments on his own. But in the case of dementia, it might be that we really want this formal testing to occur. We might really want to see not just what's the MMSE score, which is, of course, you know, we can do that in our office in 15 minutes, but what is like more formal testing show? And that usually has to be done by a psychologist or somebody with training in that area, and then who can interpret those results and work with the primary care doctor on making that assessment then of capacity. It is okay to make the capacity assessment if it's not an emergency. Sometimes, you know, over the course of many visits, it's good if you can. Maybe you can visit with the person and then develop a rapport, especially if it's someone you don't know, and then visit again, and then visit with the family, and then make your assessment. So it doesn't have to be done like right now, right in this moment, if it's not an absolute emergency. Now, when you make that decision, it will pertain to that time frame only, right? It will be like on this day when we're making this assessment, we're writing this order in the chart, this is what we're determining about capacity for this particular person. But it can be a process that occurs, the assessment, over several days, several weeks. Maybe someone's depressed, not doing what they need to do to take care of themselves. Maybe they lost their wife or their care, person that they loved, and so they meet with the psychiatrist. The psychiatrist says, "You're depressed. Do you know what this means?" "Yes, I know what that means. This is how we would treat it with this medication. Are you willing to try it, or with this therapy or something like this?" And if that person is willing to engage in that, and it's not an emergency as far as the medical issue at hand, yes, let's treat with the antidepressant. Let's see if that helps. And let's see if that improves the ability to accept the medical care that's recommended, because now you're no longer depressed, majorly depressed and withdrawn and apathetic, and just don't want to engage in that medical treatment. So there's a lot to keep in mind, but it's really good to remember that these things don't have to always be made like in that 1 hour span of talking to the patient face to face. You can take your time if it's that kind of scenario. That's nice. Yeah.
Are more questions, thoughts?
But not easy. And
No.
yeah, this isn't easy stuff. I've been thinking about capacity and making capacity decisions for 20 years, and it's not easy. It's never an easy thing, and each case is unique. Yeah, it's heart-wrenching a lot of the time. So
Yes.
yeah.
So does anybody else have any questions or thoughts? This has been really amazing. And somebody asked if you could share, if you were willing to have your slides shared, and I can email those out if you are willing to do that.
Oh, sure. As I was going through, I noticed a couple typos. So I'm going to correct that. And then I'm going to email them to you again, Terry, and then I'll have you send them out. So within like the next 24 to 48 hours. Absolutely. No worries.
Okay,
Be
that would
happy
be
to.
great. Thank you. Anybody have
Okay.
questions or
Oh,
thoughts?
and anybody, if
Yeah, I just wanted to
anybody thinks of something. Oh,
Sorry, I just wanted to say this was just so helpful because in our organization, we're certainly not the ones making those capacity
No.
assessments, but we're talking with families all the time who really do not understand what's involved or how many rights their loved one has, to be honest. So I think this is really helpful in giving me some of that language to help explain to them what this looks like and what they need to do next. So thank you very much.
oh, you're so welcome. And I mean, along those lines, like if you have the ACE with you, for example, you're talking to a patient or the family, and you can like talk about some of those things. And then, even though you're not the person who'll be making that exact decision, your input is so important. It is more, I'll argue it's more important sometimes than the clinician who comes in and doesn't know this person and anything else about it. So yes, go ahead and start to get really comfortable and acquainted with some of these, like the form and stuff like that, the ACE, because it's a really nice place to start, and anybody can start with that. Yeah. Okay.
More comments from anybody?
Thank you.
Thanks, Rebecca. Does anybody else have questions
Of
or
course.
comments for Rebecca? So I'm not seeing any or hearing any. So saying that this was extremely good today, and it's always a good conversation about capacity and competency, and this is one of the best I've ever participated in. But if you've enjoyed this, I would like you to think about other ideas that you would benefit from and that you would like to share. So one has come up into my mind, and I'm working with an attorney, and I'd like to work with the other attorney in our membership. And that is on having a digital legacy and talking about legacies and legal documents and going forward. And I have a personal reason for that, because I've met a nurse whose daughter died at 25, and there was many things involved with that people don't realize that come to the forefront. So that's one idea that I have in mind. But I heard another one today that came up, because when we're dealing with competency or capacity, particularly, and decision-making, and those that can be very stressful, would be to talk about moral distress, and that might be something to have somebody speak about if you would be interested in that. Other ideas I'd love you to put in the chat before you leave, because we would love to follow through and make these meaningful general membership meetings. And if you're finding value in this general membership meeting and how we could move forward with educating our community on end-of-life planning, on advanced care directives and POLST, and the areas revolving around that, such as funeral planning, we would love to have you be a member. It is $100 for the year. It goes to support having a website, being able to print documents as we need to and send emails out. And I need to make this clear. We are in support of the electronic POLST registry and in that education. We are two separate entities, and the Ventura County Coalition for Compassionate Care is a volunteer organization. I am a volunteer, and all of the steering committee members, such as Andrea and Martha, and King Kossoff and Diana Hawkes, who was previously employed by Community Memorial Health System, and whoever else I'm missing, Carlo, are steering committee members, and they are also volunteers. We are in support of the electronic POLST registry, but we are not supported by them, and we are supporting each other in theory of how we reach out in this community. So I'm hoping that's a clear understanding, and that as we move forward, we will hear more about the electronic pulse registry, but there's nothing to share at this time. So, but I'd like to keep you updated. So saying that, if you will put your ideas in the chat about what we can hear about in the future, that would make me extremely happy. And I think it would make our steering committee happy, because it's amazing what people want to hear and what needs to be heard. And we don't always think about it. So I appreciate your time today. Thank you. Anybody else?
Thank you so much, everyone.
Thank
Appreciate
you,
you
Rebecca.
attending.
That was amazing.
Thank you. I appreciate it, you guys. And feel free to contact me with any questions too.